Hello. Today we're going to be talking about pediatric musculoskeletal issues in children. And so looking at your chapters, be sure you look at your syllabus for your chapters in Wong. But in ATI, in the new version, it's chapter 27 talks about fractures, and chapter 28 talks about some musculoskeletal congenital disorders. And then we do have chapter 29 talks about some chronic neuromusculoskeletal disorders. Those chapters, that particular chapter will also be good when we're talking about neuro in our neuro class next week. So if you want to follow along with me with the slides, that would be terrific. Just remember that we have, you learned last semester with foundations about the physiological effects of immobilization. It's not often that we see children that are immobilized, but it's possible. So, especially if they have some kind of chronic illness, maybe CP or some kind of cerebral palsy or some kind of long-term fracture that requires traction, a Spica cast, that type of thing. So the first couple slides are just review. Physiologically, we know that if you don't have weight, that you can start getting muscle atrophy and disuse. So that's important to note for it. Within 1 week, you're going to have decreased muscle weight, increased growth of the muscle, decreased contractile force and velocity. That results in smaller, weaker muscles and eventually could result in contractures. We also know that if you're bedridden or don't have mobility, you can have a loss of calcium, which with elderly people, that would be a risk for fractures. But even children, if you're trying to repair a fracture and they're immobilized because of the fracture, like a fractured femur or a back or something, then they can have decreased calcium going on. It is a total body system physiological effect. Immobility is, it can affect cardiovascular function, respiratory function, your metabolic rate, and your kidneys. So weight bearing, the ability to bear weight, balances the bone formation and bone reabsorption. We know that also psychologically there's effects on children if they have to be immobilized or in one place for a long period of time. Movement helps us with giving us some control, helps us release tensions. Children that are isolated or in an immobilized situation can have sensory deprivation. That can equate to isolation, boredom, loneliness, and eventually depression as well. So just look at that psychological effects, feelings of helplessness, possibly delay in language, and some other things, even as severe as hallucinations and disorientation. So automatically, as we're talking about the physiological effects and the psychological effects of immobilization, I know your wheels are spinning and you're thinking, what can I do to keep the child as mobile as possible, and what can I do to help alleviate or prevent some of those psychological issues that can occur? Whenever a child is immobilized, you have to think physical and psychological, so the ABCs, everything from position changes, what musculoskeletal systems, what range of motion can you do, what active range of motion do they have. Physical therapy may be involved in order to get you a special mattress if needed. And of course, anytime someone is healing, whether it be bone fracture, they need high protein, high calorie diet. Loss of mobility can affect appetite, so how can we make the appetite increase? Maybe a referral to a nutritionist would be good too. So we're going to talk about fractures in children. A couple other things, as you can see on the slides, that could be priorities for the immobilized child. Dehydration could be an issue, growth and development. You're going to really focus on allowing as much independence and choices as possible. Use play therapy, especially when you're trying to explain the different devices, maybe the types of casts the child will use, maybe the types of traction the child will use. So be sure you do that. and help them not to be so isolated. So when we think about fractures in children and looking at your Chapter 27 and ATI, usually children get into situations where they break bones because of accidents or a motor vehicle accident. And as soon as they learn to start climbing, crawling, falling off equipment or bikes, that type of thing can make a child break a limb. It rarely occurs in infants, and so anytime an infant has a fracture, that's a red flag for possible abuse, and we have to have further investigation. So definitively, you're going to see that fractures need an x-ray, but if you have a small child, an infant or a small child, if you see fractures at various stages of healing, it could be child abuse. But be cautious, because it also could be something called osteogenesis imperfecta, and that is a genetic disorder where children have very fragile bones, and just the slightest insult or trauma or hitting can make that child fracture. The most common fracture in a child less than 10 years old would be the clavicle. So if a child's falling, they reach out, they outstretch their arms, and it makes their clavicle snap. So what happens when a child has a fracture or anyone has a fracture? The normal response of the body is to have the muscles tighten around that fracture. So the tightening around that fracture can make it tightened around a misaligned bone. So sometimes what has to happen, it's a splinting, it's like the body's way of splinting. So what has to happen sometimes is that we have to put that child in traction, and the traction can help relieve that muscle tension so that you can realign the bone. So that's one of the reasons that we put kids in traction. For a school-age child, bicycles, pedestrian accidents, skateboards, adolescents, also bikes, motorcycles, sports injuries. We have to be careful, because if the fracture is through the epiphyseal plate, there could be some problems with growing and growing in an even manner. So we have to be careful with that. If you have a break through the epiphyseal plate, then it's called an ORIF that they usually do, open reduction internal fixation. So what they'll do is they'll make an incision, they'll put some pins in. They have to make sure that if the epiphyseal plate is affected, that it gets lined up perfectly well, because of the possibility of growth disturbances. So your book goes into all kinds of types of fractures in ATI on page 296, and there's a couple here. A simple or closed fracture is a simple one without breaking the skin. If you have an open fracture or a compound fracture, that's one that goes through the skin. So there's all different kinds of fractures. There's a few others that are listed here. Complicated means a fracture that also affects other organs. So if you have a fracture of the ribs, for instance, and it punctures the lungs, that would be a complicated fracture. And the comminuted fracture is where bone fragments are in the surrounding tissue. So bone fragments are part of that. So you've got a couple others. Some in your book it says complete, where bone fragments are separated, incomplete, where they're still attached. Some others, and then of course it mentions closed, opened, or compound, and complicated, also in your book. Green stick fracture is where it's like a green stick of a tree, like a little branch that's fresh. So there's a break, but there's still a part that's keeping the bone together, and that's the green stick application. So once again, how are fractures treated? Fractures can be treated with traction, where you got the tension, the muscle tension. You're going to relax it so that the bones can realign. Possibly internal fixation, which is the surgery, and then for casts can be put on after that. Casts can be for closed reduction, where they don't have to do surgery and they can just realign the arm and then put the cast on and make sure x-ray wise that it's okay. So they can be that, and then plaster immobilizations. Casts can be plaster, or they can be plastic kind, plastic or plaster. and then once they put them on, they'll have to reevaluate and make sure things are going okay. Healing is so quick in children. It's amazing that they have such a rich blood supply that healing can occur so quickly. Osteoblast growth and calcium salts deposit helps form the callus. So you can see the times here. Newborns 2 to 3 weeks healing, early childhood 4 weeks, late 6 to 8, and adolescents about the same time frame as you would see for an adult. If you're taking a history of someone that might have a broken bone, a child, remember that infants have no verbal communication, so we're going to really rely on the parents for that and look at the symptoms. But children also may not be honest because they may be afraid that they're going to get into trouble. So they may not say, well, I jumped off the top of the roof, or I was climbing up in this tree that I wasn't supposed to be in. So remember, inconsistency in the history from a parent and the assessment findings might indicate abuse. And then what are the circumstances around it, and how honest are the children? You know, is the child giving you some indication, and as well as the parent's story? So we do look at X-ray, and we do look at the symptoms of fracture. So on page 297 of ATI, it also goes into some of these symptoms of fractures. But in general, sharp pain upon movement is classic symptom of a fracture. You might also see, as you can see from the slide under signs and symptoms of fracture, you can see swelling and deformity. This child has a bowing of their arm, bruising, rigidity, crepitus, which is a crunching sound. If a child refuses to walk or move their upper extremity, you should suspect a fracture. Also, you don't have to touch. If you suspect with the symptoms sharp pain, deformity, don't be touching that limb, saying, okay, let me just see if I can feel where the fracture is. That's not necessary for you to assess it. Ecchymosis, of course, is bruising and could have warmth or redness with some kind of inflammation area as well. The goals of management of a fracture would be to realign the fracture. We also want to make sure that there's no damage in the length of the extremity. Restore, hopefully complete restoration of the injured part, and prevent any further injury, like injury to some other organ, for instance, or a blood clot or something else that could occur from having the injury and having possible bleeding and clots and things like that can happen, nerve damage. So we want to make sure there's no nerve damage. If a child has a fractured femur or a supracondylar area of a distal humerus, in other words, long bone fractures. So the long bones are your femur, they're also your humerus. Those would require some type of hospitalization, probably some kind of skin or skeletal traction. If it's a simple reduction that's not being achieved, if you can't reduce it with just hand reduction, a manual reduction, then and it requires surgery, that's going to be a hospitalized child. If there's any signs of neurovascular problems, and we're going to talk about the 6 Ps of neurovascular red flags, if the child has such a severe bruising or swelling that you can't cast, that would be a reason for hospitalization. Or if they're so badly aligned that they need to have traction first, then that would be another reason. So the 6 Ps of taking care of someone with a fracture, you are assessing for these things. Pain, and you want to know, is it sharp? Is it aching? What kind of pain is it? You want to check the pulses on the extremity and compare it with a non-injured, so the extremity that's injured and then the non-injured extremity too. Compare them, but pulses are important, and compare other sites. You should have a pulse. If you don't, if it's 1+ or 0, a 0, of course, is a medical emergency. I'm looking for paleness or pallor, which are the signs of circulation. Paresthesia is a tingling or unusual sensation that can occur when you have a fracture. Numbness, of course, is complete paralysis. And then there is a term called poikilotheria, which means cool temperature. Think of poikilo like polar, and then thermia is temperature. So those are the 6 Ps that could be arterial insufficiency or neurovascular insufficiency. So you're out there in the field, in the soccer field, someone goes down, they think that they have a fracture. What do you do? Well, you've got a couple things, even on page 297, that ATI talks about. What do you do? Well, of course, if it's an airway issue or if they've also bumped their head, then you're looking at stabilizing that neck, making sure the airway's open. If it's an extremity, then you want to immobilize it. If it's a fracture that's compound and there's a bone coming through, you do want to cover that. You don't want to try to pull it and realign it yourself, but cover it if you can with some kind of clean cloth. So you're going to immobilize, cover, reassess the neurovascular status, but don't palpate the injury. If you can elevate, that's fine. Ice it if you can, and then call EMS to help you. You don't want to, again, cause any kind of complication. Be calm with the child, be calm with your parent. Just in case the child has a physiological shock reaction, keep that child warm. So looking on page 297, some of the priorities. ABCs, monitoring to Vadarov signs, pain, neurological status. You're not going to have all that out in a field, but you can monitor pain, neurological status, and the neurovascular status, keeping the client in a supine position, and then stabilizing the injured area. If you can elevate it and apply ice packs, that's okay. If you're in a hospital setting or an ER, they're going to probably administer analgesics as prescribed. So pain is important. Use an age-appropriate pain tool and appropriate pain management, pharmacological and non-pharmacological. Don't hesitate to check that neurovascular status frequently and report any change. And then, of course, the changes would be numbness or tingling, loss of sensation, remember, is nerve damage. And then the skin temperature is the popliteothermia. The color, capillary refill is another way of checking perfusion. It should be within those 3 seconds, less than 3 seconds for sure. So keep yourself calm while you're doing all this. Let's see if there's anything else. Remember that if you give analgesics for pain, if it's an opioid, you need to monitor for respiratory depression and also long-term constipation. But folks, kids that have fractures or get into traction need pain medicine on a scheduled basis. Let's talk about a little bit about traction here. So traction, I think you've not had traction principles before in our college, but traction is a forward force are the weights, and then the counter force would be the body weight. Of course, if you've got a small child, they're going to be trying to pull down into bed. So that friction is the patient's contact with the bed, and we want to try to avoid skin breakdown while a child is in traction. So traction helps realign bone ends. It helps rest the extremity. It can prevent or improve deformities. It also helps promote healing and immobility until the fracture can be casted. And then sometimes you'll see people that are in traction just for muscle spasms. So realignment of fragments is a gradual process. It can be achieved more rapidly in infants that have limited muscle tone, for instance, versus a very muscular teenager. After you've put a child in traction, it's important that x-ray is done to see how the alignment is. And of course, that would be in skin traction or skeletal traction. Skin traction is where you have a wrap with a force right outside the body or outside the skin. Skeletal traction is where there's a pin through a bone, and then you have the weights on those pins that are directly in the bone. Of course, there's complications with that. So if severe or soft tissue swelling or vascular nerve damage, they may put the child in traction until those complications have been resolved and casting can occur. Page 299 talks a little bit about tractions, and including different types of tractions. They mention skin and then skeletal, like we just talked about. And of course, there are some complications. If you have a pin in a bone, you have an open port for osteomyelitis. So infection is a possibility with that one. You do have suspension traction, and you have halo traction if someone has damaged their cervical spine, broken their neck, then they may need a halo traction. So some of the important strategies, here's a couple pictures of manual and skin, which is also known as bucks. And then here's one on slide 24 that shows skeletal type of traction, where it can be pin or wire, tongs right into the diameter of the bone. Some other kinds are skeletal with an overhead suspension. That is called Dunlop, and Dunlop is the one for a break in the humerus. With lower extremity fractures, sometimes they'll place kids in Spica casts. They don't always use the one that's on the 26. It's called Bryant, and it's a 90-degree angle to the hips. The buttocks are raised off the bed, and the reason that is a problem is that you can have gravitational vascular draining or a tourniquet effect, and that can cause necrosis with that. So it's not the best for drainage. So they try to use other ones besides the Bryant traction. Buck's traction is a lower extremity fraction traction, and that's skin. The legs are extended. It's usually used for short-term immobility. Preoperatively, it can be used for dislocated hips or correcting contractures, or there's a bone deformity for children called LCP, leg Caffey-Perthes disease, and it's a avascular necrosis of the femoral head, and so it can, what you're trying to do is get the femoral head away from the capsule so it doesn't cause pain, and so sometimes they'll use Buck's traction to pull that away. We'll talk some more about that in a few minutes. And then there's something called Russell traction. It has actually two lines of pull. And then a 90-degree is it's listed also here in your ATI, but it is a very popular skeletal traction. They have a boot cast and a skeletal pin. And this one is good because, they have a bar that they can use, to overhanging bar to help lift up. But it's good for position changes, toileting, and prevention of some complications of immobility like we talked about. So what do you do for someone in traction? If you'll look at some of the strategies on page 300 of your ATI, you want to maintain body alignment. Make sure that that child's body is aligned in bed, and if they keep falling down because they're so lightweight, you're going to need multiple people to help. Don't try to pull a child up by yourself if they're in traction, and do not take the weights off unless you have a doctor's order. But someone can help, one or two people help bring the child up while someone else is helping ease those the weights up. You also want to maintain good pain control for pharmacological and non-pharmacological interventions for the management of pain. If they have severe pain from muscle spasms that's unrelieved with medications or repositioning, then let the physician know, because they may need to do something else. Always think about monitoring for complications, and so some of that complications would be neurovascular disorders, or so thinking about those 6 Ps, pain, pulses, paresthesia, paralysis, poikilotheria, and I'm missing one. Okay, so we said pain, pulses or pulselessness, paresthesia, which are those abnormal sensations, paralysis, pallor was the one I was missing, and then poikilotheria, which is the cold. If you do have, also need to check for skin breakdown. With skin traction, that child, even the friction on the bed can cause some breakdown. So look on their buttocks, look at their parts that you learned in foundations that can have the bony prominences. For skeletal breakdown, those pin sites can be sites of infection. So you have to use asepsis when you clean those pin sites, checking those pin sites for the pain, redness, swelling, and discharge. And then whatever the pin care is for protocol. Every facility will have different protocol for pin care, like half water, half peroxide, or maybe just using alcohol swabs or betadine swabs. We are going to have some other issues too. You're going to need to assess the child's need for elimination, and hopefully constipation won't occur. Make sure that the equipment is in good shape. The weights should be freely hanging and never on the floor. If they're on the floor, they're not working. So you might have to get physical therapy to come and help you with that. The provider, the healthcare provider, is the one that determines how much the weight should be and what kind of traction. Your job as a nurse is to make sure all the equipment looks like it's in good order, and if not, then get some assistance with that. Overbed trapeze is important to help the client move around. Range of motion, remember to think about respiratory because we talked about the physiological effects. So instead of spirometer, deep breathing, coughing, position changes, and then helping the client be as active as possible. Hydration and nutrition, maybe some stool softeners, and then signs of infection. Compartment syndrome is a medical emergency when you're either in traction or in a cast. And that is where you have some of those paresthesias or pulselessness, but it could be neurovascular nerve compression, and it's called a medical emergency. So if you have any signs of compartment syndrome, a right answer on a test would be to notify the physician immediately because it is a medical emergency. So skin traction wraps could be removed for care, but you've got to have someone maintain manual traction when they're doing the rewrapping process, and a doctor's ordered to do that. Skeletal traction, this is just on slide 31, talking about some possible hospital protocol for skin care. Remember to use liberal use of analgesics, and during the time that the child is just in there, they're hurting from the fracture itself, but also prior to pin care for skeletal traction. About 15 minutes prior, you do want to get some medication on board. And skeletal traction can be very frightening to children, so you want to make sure that they understand what's going on. Sometimes if they're older, let them help with their pin care and their care so that there's been studies that shown that people actively involved in their care don't seem to be as frightened or even as in much pain. Remember that a complication of a long bone break, like a femur or a humerus, can be fat embolism. So long bone breaks equal fat embolism, and if that releases, it could be a PE or a pulmonary embolism. Another complication would be compartment syndrome or neurovascular changes and necrosis, and then loss of function, permanent loss of function, range of motion, which equals contractures. So when you have someone in a cast, you should ask yourself, well, what kind of cast will they use? It depends on the type of fracture and what bone has been involved, and if there's going to be any weight bearing allowed. So that's some things to think about. Usually what they do is they support the joint above and below are casted. That helps immobilize the site. Two types of casting materials. Plaster is common. It's heavier, and it does take 10 to 72 hours to dry. So with a plaster cast, some of the things that you can think about would be that sometimes in the drying process, you do want to turn the child over back and forth, a cool hair dryer perhaps. When the cast is still wet, some of the ways to handle it would be with your palms only, not to use your fingertips. That's part of the casting. I'm looking to see where casting is. Casting's back on page 298 on ATI. So that's interesting. Make sure prior to casting that the skin is observed for integrity, it's clean and dry. Bony prominences should be padded to prevent skin breakdown. So showing the procedure on a doll or toy is atraumatic care for children, especially our 3 to 5-year-olds or even young school-age kids. During the first 24 to 48 hours, you want to elevate the cast above the heart so that there's reduced swelling, and ice for the first 24 hours to reduce swelling. Every 2 hours, the person should be turned, the child turned, so that circulation can happen, and it helps with drying. Do not use heat lamps or warm hair dryers. I said a cool hair dryer would be okay. And then they can have a sling or some other support when they're sitting up. So again, some of the things: skin breakdown, remove all constricting objects or jewelry. You want to put the ID on the opposite side, and then they will use some kind of stockinette or pad for bony sites. So your job is to help with the holding manual traction while the provider puts on the cast itself. There is something called a Spica cast. Here's a little picture of it. It can be either up and down both legs, especially in a child that has like an infant after hip dysplasia, or if it's a smaller child, sometimes you can see it down one leg and then half of the other leg with bars in between, or just all the way up one leg. But the spica cast means that it's up to the waist and then all the way down one side of a leg at least. It does take the 24 to 48 hours to dry. The child has to be turned every 2 hours. And so support the wet cast with pillows. This is another one where you don't want to use your fingertips, palms only. It's heavy and it's hard for a parent to handle a child that has it. If it's a baby, they're going to have a cutout part where they can put a diaper in, but toileting is always an issue. When you have someone in a cast, watch for hot spots. Those are signs possibly of infection. If they had a compound fracture that's being repaired, you do want to monitor for any bleeding that you see on the outside of the cast. So I would circle it and put your initials and the date and time, because you're monitoring for increased bleeding. If it continues to bleed or increase, then that would be a sign that you need to contact the physician. So the priority in the first few hours after a cast is circulation. Check it every hour, post-op, and after the cast has been put on, because in 6 to 8 hours you can have permanent tissue and muscle and neurovascular damage. Remember to elevate the extremities. It's not unusual for them to bivalve a cast, and that means they put one part on and another part on and then wrap it around, so that if you do have neurovascular affected, where you have some of those signs of the 6 Ps, then someone could call the physician and you can cut that cast off rapidly if needed. Remember, these are the nursing alerts: pain or swelling, increased discoloration, which could be blood, no pulse, and unable to move or wiggle their fingers or their toes below the cast is a medical emergency, and the physician needs to be contacted. Sending a child home with a cast, it's going to require some special discharge teaching. Do they need a special car seat, for instance, if it's a spica cast? What are the care and cleaning? You want to make sure that the child, that they don't wet the cast, that they don't, make sure that no toys or anything like it, if nothing goes down the cast. Sometimes a child could get itchy spot, but this is where you don't want to put a hanger down there or anything like that. If it's a spica cast, I've seen questions on NCLEX that talk about if a child has a spica cast, what would be an appropriate toy? Well, you don't want anything small, no cars, no Legos, no crayons, nothing that they can stick down in that spica cast. Something like a soft toy, or maybe a storybook, something that you know that they're not going to stick down the cast and it gets stuck. There are still nutritional concerns. We still want to increase fluids and a high-protein diet, and then also positioning and toileting issues. The person may need some special help at home with a child, especially if it's an older child. This is a very heavy cast. When a cast is being removed, it can very well frighten a child because it looks like a saw. So the noise of it and the fear of being cut, describe it like a fingernail or hair or fingernails being cut. When the cast comes off, the child's skin can be very smelly from all the excessive cells. So you can use olive oil or lotion, and don't force tissue off. Tell the parents not to try to force it off because it can cause bleeding, which is a sign of infection. Bleeding or can lead to infection. There's a couple other kinds of use of traction. Something is called distraction care. Your Wong talks about distraction care, and it is a process where they separate opposing bones to encourage regeneration of new bone. So if you have a child that has unequal lengths of extremities and legs, they may try to do that, where they would cut the bone and have it a little bit separated and then keep it there. So the bone ends, this is just on slide 42, talks about it. The bone ends are cut and stabilized slightly apart, and it grows about 1 centimeter a month, and they can actually make a child grow 15 centimeters in length. Full weight bearing is not allowed until distraction is complete. So this is on slide 43. It talks about a type of external fixator. It's called an Ilizarov, and it lengthens the bones. You can see it on this picture. It's like an outside structure that looks like a the building structure almost, but it's wires, rings, and rods, and you can see how tough that would be. So that is done until the bone growth has happened, and then the cast would follow for 4 to 6 weeks. What a challenge this would be, though, this external fixator, with things like clothing and no weight bearing. So this child's going to have either crutches or a wheelchair for the period of time that it takes for this to grow. And so again, full weight bearing until it is complete. So, and then a cast after that. So this is a very interesting thing that can happen to children. If you have someone that has distraction care, we need to educate the parents about pin care, because it is pins into the bone, and the use of crutches. If the child's old enough, we're going to have them help as well. As I said, active participation can sometimes mean decreased pain for children. So once again, special clothes, can they get some help at school, and their friends' support, because they may feel like an oddball with this external device. Another condition that can happen to children that's musculoskeletal is congenital hip dysplasia. And you may have already talked about this in OB with some congenital defects of newborns, but usually it's a shallow acetabulum subluxation dislocation. The causes are on your slide on 45. Maybe estrogen creates laxity of the maternal pelvis. Could be a breech position, or maybe twins in utero. Maybe the baby was large, or in some cultural issues where in some Far East issues, they wrap the baby so tightly on boards it can cause a subluxation. Your dysplasia of the hip is on page 309 in ATI, talking about the different kinds. So we do check, we assess this at birth. So what we do is we look at several things. When we're doing our newborn assessments, we're looking at their hips, and we can pull their hips up, and then with our fingers around the acetabulum, we can pull the legs out in abduction, and we're feeling for a click, and it's called positive Ortolani, and its hip is reduced by abduction. And then if you pull the hips back together and then pull the legs out, you can also see if they're uneven, and that is a Barlow hip test. You also can just look at the back of the child's little gluteal folds, and asymmetry of the gluteal and thigh folds is another thing that we're looking at. So you might see less mobility and flexibility on one side. This is kind of a huge, looking at a baby that's been probably premature and also in a crowded position in utero. So what do they do for these kids? Well, they put them in something called a Pavlik harness, and they'll check this on ultrasound at 2 weeks to determine the head of the femur, cartilaginous head of the femur, and then if X-ray for kids that are more than 4 months old. Soon as it's diagnosed, treatment should occur, and it really depends on the child's age and the extent. If it's caught in newborn to 6 months, they do put them in this Pavlik harness. And this is a picture of the Pavlik harness on slide 47. It is a harness for about 12 weeks. You want to check the straps every 1 to 2 weeks for adjustment with your physician. And of course, if they're in that, they're going to need skin checks and neurovascular checks. The family should not touch the straps, and they can use undershirts, knee socks. They need to check the skin underneath the straps as well. Generally speaking, this is used 24 hours a day for a period of time, even up to 3 months if need be. But generally, there's some averages about that. You can eventually reduce traction. The 6 to 8 months, they might be able to gradually reduce the dysplasia hip by cast, or need open reduction in Spica cast. Here's another picture of a Spica cast. So they're also talking on page 311 of the hip Spica cast that can be put in, and some of the things that involves. So client education relating once again to cast would be positioning, turning, how to do neurovascular assessments, Kira of it, sponge vasts to avoid wetting the cast. waterproof barrier around the genital opening of a spica cast, because that opening can get really soiled and smelly. And then maybe the use of a stroller wagon, how to use different car seats for the child like this. Early assessment and intervention is important for a positive outcome. We do want to make sure that the Pavlik harness is used appropriately, and then cast of the child. It really is hard, because if a parent is having to deal with this Pavlik harness and then casting for a long period of time, some of the developmental stage, some of the physical development of the child might be slowed down because they're in this position and in this casting and immobilization. There's a couple other things. A congenital clubfoot is another type of a congenital disorder, page 307 in ATI. So there's some terms that you can use. You can see that the term ankle is talipus. Varus means an inversion or a turning in, and valgus is an eversion type of turning of the foot. So it could be because of crowded position or arrested embryonic growth, some of those things. Usually prenatally, ultrasound could identify the deformity. If it's a mild clubfoot, then it can be treated with exercise and usually resolves on its own. Maybe some serial casting. Serial casting is where they put a cast on, a series of casts shortly after birth, and then continue until maximum correction is accomplished. And sometimes it can be just like every 1 to 2 weeks they'll turn the cast a little bit differently to help straighten the foot out. Tetragenic is a type of clubfoot that also is associated with congenital abnormalities, and that one might need a surgery. And then a true clubfoot is a bony abnormality, and you can see how significant that particular one is, and that would be where they would have to do some kind of surgery to help with that. So page 308 talks about congenital clubfoot, where you might have to remove part of the bone and then refuse two or more bones together. So that's where you would have more complex surgeries. You want to correct the deformity and then maintain the correction until the muscles are stretched or balanced, and then follow up. So here's a little bit of a note on serial casting: gradual stretching every few days for 1 to 2 weeks. So they may keep turning it. It takes about 8 to 12 weeks for it to become re-stabilized, and the optimum age for this type of serial casting is 4 months up to 1 year. So once again, if you're dealing with cast assessment, circulation, comfort, and then parental teaching and updates on the progress. Another type of condition is called LCP, Lakes-Cathy-Percy disease, and I saw a little blip on that on page 308, not very big, but remember that it's avascular necrosis of the femoral head. It affects boys more than anyone else. So what happens is this young boy starts limping and starts complaining of pain. And the parent doesn't always take them in, but if they do, they may diagnose what stage it is. There are different stages. So some of the stages are avascular stage. These stages are listed in your Wong book, but avascular, and then if that stage is caught and they can put this child off their weight bearing, there also can be revascularization, reparative, and then regenerative, where there is actually healing. It can take up to 18 months for several years for this to occur. So it is a very long process, but you're trying to prevent damage, permanent damage to that femoral head, which would be significant. So painless, intermittent painless limp or thigh pain, hip stiffness, shortness of the affected leg. One of the most important things that you can do with this is get the person off that leg. So treatment, patient-centered care would be varied, but maintaining rest and non-weight bearing are important. And eventually they may need total hip resurfacing and replace the hip joint if they didn't catch it on time and there is actually damage. So non-weight-bearing treatment, and then of course helping them with some developmental issues. So classic parent may see the child limping. They could complain of hip soreness, aching, stiffness, could be constant or intermittent. Most evident pain and limp is on a rising at the end of a long day of activities. Let's see. So the treatment for LCP is rest initially. That preserves the head of the femur and relieves the pain. And then non-weight-bearing activities because it reduces inflammation and restores motion. Later, as the child is starting to have some remodeling, you can do range of motion exercises, possibly traction. Totally, it could be up to 2 to 4 years for healing. So you can imagine how devastating that could be for an 8 to 10-year-old young boy not to be able to do fully functioning and maybe playing sports, that type of thing. The earlier and efficient outcome, the treatment and will depend on the outcome. So younger children have a better possibility for complete recovery because they have more prolific cartilage and healing. With LCP, remember parental and child teaching about the length of time this could take, how important it is that they comply with non-weight-bearing treatment, and then, of course, learning the activities during the non-weight-bearing period so that child still stays up with their school and friends and that type of things. Support for pain control and emotional support. Another musculoskeletal issue is scoliosis. And scoliosis is on page 314 of ATI. You can see that they call it an S-curve, but it can have a lateral curvature, can cause some spinal rotation, which means the ribs are asymmetrical. It can cause some thoracic hypokyphosis, and it's not uncommon. You should start checking for it really in the prepubescent child. So in middle school is when we really start looking at it during growth spurts and during adolescence. The thorough assessment needs to determine what the involvement is. But for us as nurses, if we could just do a check, like put our hands on top of somebody's shoulders, put them underneath the scapula, and put them on the hips. First thing I'm going to be looking for are my hands even on those areas, or is one hand higher than the other? Then if you see, then have the child bend over and you're looking down straight across. If you see a humping on one side, that could be part of that kyphosis that is occurring. You should refer if you see any kind of S-curve or any kind of humping of that rib cage. And less than 10 degrees are considered postural variations if you referred someone. If it's greater than 20, less than 40, they are probably considered mild, and if they're non-progressive, may not need treatment. Over 40 degrees, what they'll try to do possibly would be some kind of a brace and possibly surgical stability. The surgery is very serious, invasive. It would be straightening with some internal fixation and rods and bony fusion, so it can be very complex surgery. Let's see what else they talk about here. The ATI talks a little bit about bracing that we talked about. It can slow the progression of the curve. And sometimes, though, it can also cause some, we're talking about adolescence, pre-adolescence and adolescence. So sometimes they'll use those underneath their clothing, but it's very hard for a child that's in that age group that's trying to fit in to have something that looks abnormal. It does talk about the surgical intervention, which is a spinal fusion. And of course, this is a major surgery. So preoperatively, do a type and cross match. The child will be in ICU, let them know what's going to happen post-operatively. They're going to be using PCA pump. They're going to have to log roll after rod rod placement because of the spinal fusion. So it's going to take more than one person to do that, more than one nurse. All the post-op things, bowel sounds, monitoring H&H for bleeding, blood transfusions as needed, and then age-appropriate activities and opportunities. Preoperatively, you do want to do the use of incentive spirometer, how they need to log roll, what are some of the pain measures you're going to use, And then post-op, still wanting them to be independent, keep in touch with their friends, that type of thing. So there are some specific things to talk about as far as getting them home. You still want to keep them as independent as possible, and then if there's any complications. The complications that can occur with scoliosis would be the breathing difficulties with severe curvatures, lower self-esteem, and that has to relate to adolescent care. Infection after surgery, of course, is a possibility. And then some of the other things that they need is what would be the best thing for the reinforcement. Depends on what the follow-up procedure is with the doctors. There could be spine or nerve damage, corrected scoliosis. So your 61 slide is talking about your pre-op and post-op care. Remember, adolescents need control and ability to make as many decisions as possible. Another musculoskeletal kind of issue is idiopathic juvenile rheumatoid arthritis. It's called idiopathic. Here it's called juvenile rheumatoid arthritis. The page number for that in ATI is page 334. And it is an inflammatory autoimmune. You may have already talked about rheumatoid arthritis in adults, but this is JRA, or your book, ATI calls it JIA. Same thing. It can be just joints, and it's usually bilateral, multiple joints, but about 10% can become systemic and involve everything from fevers, rash, liver and spleen enlargement to pericarditis and lymphadenopathy. So about 10% kids can get systemic. What you see with rheumatoid arthritis would be inflammation of the synovial fluid with joint swelling. Effusion means swelling. Erosion can happen and destruction of cartilage, and then it can become harder. You can get adhesions on the joint surfaces, and then eventually they call them like frozen joints. Ankylosis is where the joints do not work and they become frozen. So some of the symptoms for even children would be when they wake up, they have stiffness and swelling. So you want to get them their medications early and get them into a warm bath. Warmth to touch, loss of motion, and then joint swelling. The classic sign of juvenile RA is morning stiffness, or it can be after a long day with activity. So early symptoms, decreased range of motion and muscle spasm. Later, you're going to see more of the limitations of range of motion, ankylosis, and this child could eventually become needing supportive devices, braces, or wheelchairs, whatever the case may be. You want to teach that flare-ups can occur because it's autoimmune with infections and injuries, and some of the medicines that they may use for children can also cause a lowered immune system. Recognize and treat infections. The goal for this disease is to support and preserve joint function, prevent deformities, relieve symptoms, and keep them as active as long as possible. Usually it's managed at home unless they've had some kind of exacerbation that might need some special care. Some of the management they use, drug management, would be steroids, NSAIDs, immunosuppressors, and I want to just tell you guys that they do use aspirin in children for JRA. Remember, we don't use aspirin when a child has upper respiratory infection or that type of thing with fever, but for juvenile rheumatoid arthritis, they do use aspirin therapy in children. It helps with the inflammation. Other supportive management might be physical therapy or heat, hydrotherapy, and also exercise. Let's just look and see if there's anything else that we're missing. Sometimes the lab tests can show something called anti-CCP antibodies before the disease occurs. The ESR could be elevated, maybe not. The rheumatoid factor, they do have an RH factor. It's rarely detected in children. You might see on x-ray increased synovial fluid in the joints. That could be, at least get a baseline of that. Some kids have something called uveitis, which is inflammation of an eye. So again, care is primarily outpatient. Sometimes they need support group. Splints can be used at night to help prevent decrease pain and prevent flexion deformities. Heat or warm moist packs prior to exercise. So I'm just telling you, first thing in the morning, the child should have their NSAIDs and get a warm bath if possible. Good diet, well-balanced diet. Make sure they stay involved in school and with their peers. Some of the NSAIDs that are listed are ibuprofen, naproxen, Talmetin, which is Tolectin. They can also have other types as well. Sometimes they use Rumitrex in these children, which is the methotrexate, and it is a cytotoxic disease-modifying anti-rheumatic drug. It slows joint degeneration, and so that can be used with the NSAIDs. If you're going to use that, you need to monitor liver function tests. Adolescents don't need to drink, avoid alcohol, and you don't want to have a child get pregnant while they're using this because of the birth defects that can occur. The corticosteroid that's listed in your book is called Deltazone, and it can it reduces inflammation and helps with the pain. It is you want to use the lowest effective dose possible because you know long-term steroids can have other effects, and then you'd want to taper it off. They can also use something called Enbrel, and it is a tumor necrosis factor blocker. It's another type of disease-modifying anti-rheumatic disease. And let's see. It can be used when methotrexate is not helping. Physical therapist, like I said, is going to be involved, all those folks. Make sure they're compliant with their medications. The prognosis is 30 to 40% with active disease, still have the active disease 10 years after diagnosis. They can have substantial disability, and also we want to let them know that long-term drug therapy may be possible. It's best if there's fewer joints involved. That usually helps, and of course if it's not systemic. Another disease that I want to talk about that's not on your slides is the muscular dystrophy, and muscular dystrophy is on page 337 of ATI, and it is considered a progressive degeneration of skeletal muscle groups. So the most common of those are Duchenne, and Duchenne is onset is between 3 and 7 years of age, and usually what happens is that they see that their children have a delayed walking. That's one of the signs, delayed walking. Another sign would be that they do have some of these, they can test, the lab tests can show through muscle biopsy that they have some degeneration of the muscle fibers, and that's another way of telling. But if a child is not walking by 2 or they fall a lot, those are common assessment findings. Some other ones you can see on page 337 would be fatigue and muscle weakness. I talked about the unsteady gait. Lordosis is the sway back, delayed walking. They have a hard time rising from a seated position, maybe some mild cognitive delays, and progressively difficult walking. Maybe they're unable to walk by the age of 12 years old, and progressive muscle fiber degeneration, which is muscle atrophy. By the time they're 20, they start getting respiratory and cardiac difficulties. So the care for someone with muscular dystrophy would be to support and have their, continue their muscle function as long as possible. So you have to assess, can they take care of their ADLs? What is their respiratory function? What are some long-term things that we can get in place for this person? Physical therapy, occupational therapy. Make sure that they are independent as long as possible, do range of motion, keep their body alignment appropriate. maintain their respiratory function as long as possible, using incentive spirometer, coughing devices, and if need be, oxygen and other things as well. Some of the treatments of muscular dystrophy are similar to what we saw with rheumatoid arthritis. They may use prednisone or deltazone. They also, if they're on there, of course, we're going to watch for infection. They also need some collaborative teamwork, maybe a neurologist, physical occupational therapist, respiratory therapists, and then as the disease progresses, respite care, long-term care. Surgical intervention can be used for repair of contractures or possibly gastrotomy tubes or tracheostomy. Complications of MD would be respiratory, and that's what usually children die of, which is the respiratory muscles are unable to maintain the child. One of the famous advocates for muscular dystrophy was Jerry Lewis. He always would have he'd call them Jerry's kids, and he would have telethons raising money for this. So it doesn't, a lot of times the kids do not have cognitive disabilities as much as physical. So you've got really bright kids that just don't have muscles that are working. So I know there's still a lot of research out there. All right, so this concludes our discussion of musculoskeletal issues, and thank you so much. If you have any questions, bring them to class.